Intuitively, when you learn echocardiography, you always focus on the left ventricle. However, the right ventricle is equally important, especially in clinical situations, for example, as pulmonary hypertension. The right ventricle is actually more difficult to assess because it has a unique physiology and anatomy. In this presentation, I would like to show you this unique physiology and anatomy, and also show you how to quantify the size and the function of the right ventricle. The first thing to consider is that the right ventricle is located anterior and the apex is more cranial, and that the left ventricle is actually wrapped around the left ventricle. The shape of the right ventricle is that of a U, where you have an inflow tract and an outflow tract. The wall of the right ventricle is thinner than that of the left ventricle. It's only approximately 5 millimeters. And we have very strong trabeculations, and one of the most prominent trabeculations is the so-called moderator band, which we will see later. This is a four-chamber view, an angulated four-chamber view of the right ventricle, where we can see these prominent trabeculations, very strong trabeculations. And in this four-chamber view, we see the moderator band, which transverses the right ventricle from lateral towards the septum, and it's probably also involved in the conduction system. The function of the right ventricle is different than that of the left ventricle. It has more the function or more the physiology of a bellows, where the longitudinal contraction is more prominent than the radial contraction. This is also shown here in this diagram, which measured the radial and longitudinal contraction in the right and the left ventricle to compare the two. You can see, while the left ventricle contracts more radial, the right ventricle contracts more in a longitudinal direction. But first, let's take a look how we can actually image the right ventricle. From a practical point of view, this is how I would recommend to image the right ventricle. First, I will show you how to image the right ventricle from the apical view. This would be the classical four-chamber view, but to get a better appreciation of the wall, I would rotate the transducer and move the transducer more lateral, and thereby get a much better contour of the right ventricle. So here you can nicely see the trabeculations and the lateral wall, and thereby perform a much better assessment of the right ventricle. From the apical view of the right ventricle, we can also assess the different walls of the right ventricle. Similar to the left ventricle, where we perform a two-chamber view and an apical long axis view, we can do the same actually for the right ventricle as well. To get such a view, it is important to first try to bring the right ventricle into the center of the image. Remember, we always rotate around the center of the image. And once you have that, rotate counterclockwise, and then we will all of a sudden get a view which we would call the two-chamber view of the right ventricle, where we can see the posterior and the more anterior portion of the right ventricle. If we rotate even further, we will then get the so-called RV inflow outflow view, which is a bit difficult for here to get. Okay. Let me just try this again. So this would be the inflow outflow. He's very skinny, so it's difficult to visualize the pulmonary artery. But what you can appreciate here, this would be the inflow part, where you get the inflow into the right ventricle, and this would be the outflow part into the pulmonary artery. It is also very helpful to use the peristernal approach to look at the right ventricle. I will show you how we can visualize the right ventricle from a peristernal approach. First of all, we have to get a nice classical long axis view of the left ventricle, And from this view, all we have to do is we have to tilt the transducer downwards until we see the tricuspid valve. This is tricuspid valve right here. This would be the right atrium, and this would here be the right ventricle. We do not see the apical portion of the right ventricle. We only see the basal parts of the anterior wall and parts of the posterior septal parts of the right ventricle. But nevertheless, this is also an important view to look at the right ventricle. Again, in summary, which are the imaging views you can use? The parasternal long axis view only gives you a partial visibility of the right ventricle. The short axis view helps you to assess the difference in size between the right and the left ventricle and maybe the free lateral wall. The four-chamber view gives you a very good appreciation of right ventricular function, especially the longitudinal contractile component. And you can also see parts of the right ventricle in the three-chamber view. However, this view is not suitable to really assess right ventricle function. Which other views are available? The parasternal right axis view, a very good view to look at the free wall of the right ventricle here, the anterior wall. The parasternal short axis at the base is maybe not as good to really look at right ventricular function, but you can see the right ventricular outflow tract very nicely. The subcostal view of the right ventricle, a very important view. Very often you will get a very good image quality of the right ventricle here because you can get a good delineation of the free right ventricular wall. And the subcostal short axis view, where you can also see the right ventricular outflow tract. There are several ways to measure right ventricular size. You can perform diameter measurements, visual assessment, calculate the area of the right ventricle, and perform volume calculations. However, be aware that it's sometimes not so easy to quantify the size and volume of the right ventricle because of the unique shape of the right ventricle, because of the trabeculations, and because of the poor lateral resolution. A more historical way of measuring the right ventricle is with the help of M-mode. However, this measurement is fairly inexact, and I would probably prefer to use the 2D measurements. Let's take a look now at how we can perform these 2D measurements. To get a quick reference or information about the size of the right ventricle, it's good to just perform a very simple measurement, the width of the right ventricle. How do we do that? Well, first we get a four-chamber view. Again, I would try to tilt the septum so that we get a better appreciation of the lateral wall. Then we would freeze. We would measure from the lateral wall to the septum and get a normal size of the right ventricle, which is 31. What is very important is that you are fairly apical if you perform this measurement, because if you move the transducer further cranially, you will see that the size of the right atrium all of a sudden appears to be larger. This is due to the fact that the right ventricle is located more cranial than the left ventricle, and that the biggest width is more in the cranial region than in the apical region. So this is important to appreciate. Another just short way of looking at the size of the right ventricle is just by comparing the left ventricle to the right ventricle. In this case, it's quite apparent that the left ventricle is much larger or larger than the right ventricle. Another way of going about is just by looking at the right ventricle on a 2D image, by visual assessing the size, and in particular by comparing the size with that of the left ventricle. The right ventricle is usually much smaller than that of the left ventricle, usually maximally 2/3 the size, and if it is equal in size or even larger, you can assume that the right ventricle is dilated. Here we have a patient with a normal or small right ventricle actually, and a patient with a large right ventricle, which is larger than the left ventricle. You can do that also in a four-chamber view, or actually even better in a four-chamber view. Again, two examples: a normal right ventricle, a dilated right ventricle, which is larger than the left ventricle. To quantify the volume or the area of the right ventricle, I would again use the same view where we optimize the image to see the lateral contours. Okay, then again, I would freeze the image somewhere in diastole. Let me see if I can get a better image somehow. Okay, and then I would perform a contour measurement where I start at the tricuspid plane. And what you can see very nicely here is that it's very difficult actually to really assess the endocardium here, simply because the right ventricle has so many trabeculations, so it's kind of difficult. But in any case, what you would have to do is you would try to cut away the trabeculations, and we would get a measurement of 19.6, so almost 20 square centimeters. Again, a normal value. So this is the area calculation of the right ventricle, tracing and contouring the wall of the right ventricle, and then the machine actually does the rest and calculates the area. The normal values, below 18, above 32 would denote severely dilated right ventricle. What I find so important is that if you really have an enlarged right ventricle, you have to find a reason for this dilatation. Of course, you also must consider that maybe you just overestimated the size of the right ventricle and that there is some pitfall that led you to measure a too large right ventricle. So what are the potential causes of right ventricular dilatation? Pulmonary hypertension, tricuspid regurgitation. Here you see such an example with a broad regurgitant jet which causes massive volume overload and thereby dilatation of the right ventricle. An atrial septal defect which also causes right ventricular volume overload. Dilated cardiomyopathy, possibly because the right ventricle is also affected. Myocarditis, right heart infarct, pulmonary embolism, or right ventricular dysplasia. Again, this is such an example of a patient with right ventricular dysplasia and the typical findings. We'll talk more about that when we come to the pathologies. There are a number of ways to quantify right ventricular function. One thing which I believe is very important is that you always use visual assessment. To be able to interpret the right ventricle, however, you need experience. So don't forget to look at the right ventricle when you perform echocardiography. To perform measurements of RVF, you can use several methods. One is to measure the tricuspid plane excursion, which is the so-called TAPSE. You can perform fractional area changes, or you can use the tissue Doppler imaging velocity of the right ventricle. Let's first look at right ventricular function visual assessment. These are two examples. On the left-hand side, you see a patient with a normal right ventricular function. You see there is normal inward motion, also normal longitudinal motion and excursion of the tricuspid plane, opposed to this patient where we have a reduction in right ventricular function, especially here in the more apicolateral region. Again, note that both patients have a dilated left ventricle, which shows a reduction in left ventricular function. The tricuspid annular plane excursion is performed by using an M mode, which is placed across the tricuspid annulus, and the motion of the tricuspid annulus is measured with the help of M mode, here between systole and diastole. The fractional area change is measured using contouring of the endocardium at diastole and at systole, and by calculating the fractional change between these two measurements. Here you see the normal values. Above 39 would be normal, both for males and females. Severely reduced below 25. A nice way of looking at right ventricular function is by using tissue Doppler. By placing the sample volume in the lateral wall of the right ventricle, you can nicely assess the longitudinal component of right ventricular function. I personally prefer this method opposed to the tricuspid planar annual excursion that we measure with M-mode. But let's take a look at how we perform this measurement. So this is how you would perform a tissue Doppler evaluation of right ventricular function. We do that from an apical position. We optimize the right ventricle. The next thing we do is we try to reduce the sector width simply because we increase the frame rate, which is important for tissue Doppler. Then we would put the color tissue Doppler display and the pulsed wave Doppler tissue display, freeze the image, perform a calculation of the maximum velocity during systole, which is 0.12, in this case normal. This is systole, this is isovolemic contraction, and here this is obviously diastole. So here are the causes of systolic right ventricular dysfunction. Pulmonary hypertension, no matter if it's precapillary or postcapillary. Here this is an example of a patient who has precapillary severe pulmonary hypertension with right ventricular hypertrophy and a reduction in right ventricular function. I believe you can see that visually very nicely already. Patients who have volume overload, in the end stage of volume overload, as in tricuspid regurgitation or pulmonary regurgitation. Dilated cardiomyopathy, we saw an example previously. Right ventricular infarct, right ventricular dysplasia, as in this case, very often you would see regional wall motion abnormalities and aneurysms in these patients. And also in patients following heart transplantation, often this is an early sign of rejection. I believe this information will provide you with a basic armamentarium to allow you to assess the right ventricle. However, be aware that there's a number of developments which are now being tested which could help you in the future, such as speckle tracking or 3D echocardiography.